Good morning. So we will start this quest, and we will start with a prayer. I invite Dr. Jansi for leading the prayer.
Let's pray. Father God, we come in your presence this morning, Lord. Thank you for attending the day which you gave us. Even as we come together as a faculty together in this auditorium to listen to this quest, let it be a wonderful learning experience and help us to improve our practices so that the patients we care for will get the best. We ask this in Jesus' precious name. Amen.
Thank you. And today's quest is a very important area. It's an antibiotic therapy in gram-negative infection, which is always a nightmare, especially when the patient is in ICU, a lot of confusion, which antibiotic to use and escalate. And I invite Dr. Grace to moderate the session and introduce the topic and speaker.
Good morning, everyone. Like we all know, antimicrobial resistance has become one of the major global threats that we are facing today. And according to the WHO, by the year 2050, the antimicrobial resistant related deaths are going to be more than 10 million a year, which will surpass all the other major indications like even road accidents, cancers, because we will not be having sufficient number of new antibiotics to treat this ever-evolving multi-drug resistance and extreme drug resistance. And especially for a country like India, where the expenditure for treating the patients are usually from out of the pocket. On a daily basis, we see that when we have carbapenem-resistant organism, we know that patients are not affording the care and they would go for a DNI, DNR, and eventually die of sepsis. So this is becoming more and more nightmare, a reality actually, and this is why we need to address AMR in the best possible way with the best possible practices, but making sure the patient gets the rational therapy and also making sure while we prescribe that we are not inducing more resistance to a country, especially like India, where AMR is the highest. We are having the highest antimicrobial resistance burden also. So with that introduction, Dr. Imtiaz will be taking us through the antibiotic therapy with gram-negative infections. For India, again, unlike the West, they are more struggling with the gram-positive resistance, but for us, it is the gram-negative organisms that pose us a great threat. So Dr. Imtiaz will take us through the latest guidelines based on the Infectious Disease Society of America that is applicable to us. It's not just like because it's the West we can't apply it. The basics are the same, the teachings are the same. So whatever we can absorb from them based on our resistant data, we must acknowledge that. So Dr. Imtiaz will be taking us through that. So I would like to introduce Dr. Imtiaz to you. So Dr. Imtiaz is currently serving as a consultant in infectious diseases at BCMCH. He has completed his 6-year integrated post-graduation, that is the MD and DM program from AIIMS, Delhi, and where he served as a senior resident. He holds an MBBS degree from Maulana Azad Medical College, New Delhi. So his clinical area research interests include HIV, drug-resistant tuberculosis, fungal infections, and infections in critically ill patients. He has contributed to the national TB guidelines and has several publications in the peer-reviewed journals. So he's a gentle walking encyclopedia that I would call him. Very gentle in his interactions, but very knowledgeable, but very polite, very humble. So with that, I would like to introduce Dr. Imtiaz for taking us through this quest.
Very good morning to respected faculty, dear colleagues and juniors. So before I start, here is a QR code. I would request everybody to scan this QR code. There will be a few MCQs which all of you are required to answer those MCQs. So with that, I start my presentation. I'll be speaking about gram-negative infections. So, as Dr. Grace has rightfully pointed out, in a span of 50 years or so, this AMR, it has increased drastically. And it is expected that in the near future, it will be a major cause of mortality among the human population. In order to tackle this problem of AMR, what WHO has done is they have classified the various problematic areas, the various problematic organisms, and the problematic mechanisms of resistance. It has classified it into critical, high group, and medium group. We can see in the critical group, we have organisms like the carbapenem-resistant Acinetobacter baumannii, also known as CRAB. We have the ESBL enterobacterials and the carbapenem-resistant enterobacterials, the critical group. So as of today, we will be discussing mainly the critical group, the mechanisms of resistance in the critical group, and what antibiotic therapies we can give in the critical group. We won't be discussing the high group and the medium group. Before we proceed, just a few words on the definition. So whenever we tell an organ, this is an MDR organism, this is an XDR organism, what do we mean? So whenever we say that the organism is MDR, it means that it is resistant to at least 3 antimicrobial category of drugs. And when it becomes an XDR, it is resistant to all but 2 antimicrobial categories. PDR, pan drug resistance, it is non-susceptibility to all antimicrobial categories. And then we have the DTR. For example, we have the difficult to treat Pseudomonas. So this is actually when the all the first line therapies indicated for this organism, the organism has developed resistance. For example, in the case of Pseudomonas, it might be resistance to the meropenem, resistance to fluoroquinolone, resistance to ceftazidime. So whenever all the first line choices, they have become resistant, it is called as a DTR. So my discussion mainly will be based on the ITSA guidelines which were released in 2024. So before we proceed, just a brief overview regarding how the various antimicrobials they work. So of the various antimicrobials which we use daily, I believe that the most common one which we use is the beta-lactams. Beta-lactams, for example, it might be, say, ceftriaxone, meropenem, piperacillin tazobactam. It acts on the cell wall. It disrupts the cell wall synthesis. So how does a beta-lactam group of antibiotic it acts? So the beta-lactam, once it is inside the human system, it crosses the human plasma membrane. So it approaches the cell wall of the microorganism. So in gram-negative, we know in a gram-negative organism, they have 2 membranes. They have the outer membrane and they have the inner membrane. So this beta-lactam, it enters through the outer membrane through a channel which is called as the porin. Now the porin is utilized by the organisms in order to, for the influx of various critical nutrients for the organism. So the beta-lactam, it utilizes this porin, it gets inside. And once it gets inside, it attaches to these structures. What are these structures? This beta-lactam, which may be a penicillin, it will bind to these. So these are known as penicillin binding proteins. In reality, they are actually transpeptidases. They are helping in building up the peptidoglycan. We know that the peptidoglycan, it gives structural integrity to the cell wall. And once this peptidoglycan is disrupted, the cell naturally dies. So this beta-lactam, it comes, it attaches with the the penicillin binding protein, because of which the peptidoglycan is disrupted and the cell and the bacteria dies. However, bacteria, they have now learned to acquire resistance. How do they do it? They can do it in various forms. Either number one, through the porin, which led to the ingress of the antibiotic, they can just lose this porin. So this particular step of losing the porin, it comes at a fitness cost, because now the bacteria, they won't be able to increase the critical nutrients. However, the bacteria has decided that the cost of losing this critical nutrients is much lesser than dealing with this antibiotic. Once, if the antibiotic, if it comes inside, the bacteria might use something called as an efflux pump, which pumps the antibiotic out of this intermembrane area. Another thing which the bacteria can do is it can lead to the creation of certain enzymes which are known as the beta-lactamases. The beta-lactamases will break this beta-lactam ring. And finally, what this penicillin binding proteins, the bacteria can just change the penicillin binding protein. For example, initially, say the bacteria was creating penicillin binding protein type 1, now it has changed into, say, penicillin binding protein type 3. So these are the various ways in which a bacteria gains resistance against this beta-lactam group of antibiotics. All of us know that the most in gram-negative organisms, the major method by which resistance is gained is through the beta-lactamases. So we created antibiotics, the bacteria, then they created beta-lactamases. Then what we did was, in order we humans, we created the beta-lactam inhibitors, the BLIs, to inhibit this beta-lactamase so that our beta-lactam could work properly. I will focus on this later on, but just for now, there are two, we can classify the beta-lactams as the older beta-lactams. For example, in amoxiclav, cephalosporin sulbactam, piperacillin tazobactam, these are the older beta-lactam inhibitors. Apart from that, we have the newer beta-lactam inhibitors, which are the vaborbactam, relebactam, and avibactam. So this is the way by which bacteria which has initially no resistance, it acquires resistance. Beta-lactams, now there are lots of beta-lactams actually, innumerable beta-lactams. So they have actually been classified into various groups. The one which we commonly follow is this Ambler-Bush-Jacobi classification system. It seems very complicated, but as of now, I just want you to know that it can be classified broadly into 4 types: Ambler type A, type B, type C, type D. The details of which I will go into later on. So we spoke about acquired resistance. However, we must also remember that there are certain bacteria which will have intrinsic resistance. This bacteria has been created such that it is already resistant to a particular antibiotic. It does not need to acquire any special mechanism. It does not need to acquire any special mutation, plasmid to gain resistance to that antibiotic. So whenever we come across such microorganisms, for example, in the enterobacterials, we have the Proteus group, we have the Morganella and the Providentia and the Serratia. We can see that they are resistant to colistin. Colistin happens to be one of the most potent antibiotics we have. And if we end up giving colistin to these organisms, it won't work. So this is one thing we need to keep in mind. We have a similar profile for the non-enterobacterials as well. So with this, I'll come to my first case. A 5-year-old female who is adequately immunized now presents to you with a 2-day history of fever, headache, vomiting, and burning micturition. On examination, you don't find anything. You send for investigations. You see that she has a very elevated WBC count with a raised CRP. Urine routine you have sent, and you can see there are more than 40 WBCs in the urine. You have also sent for a urine culture. So now your provisional diagnosis is a complicated UTI, and you start the patient on cefotaxime. But however, with the passage of time, on day 3, she is still having fever spikes. At this point, you decide to send for a blood culture for this patient. Blood culture, initially the lab informs you that they have, on microscopy, they have seen gram-negative bacilli. And at this point, the CRP has further increased to 25.6. So at this point, you order for an ultrasound, USG KUB, and they report it as having no hydronephrosis, no focal bacterial nephritis, and there is no renal abscess. The next day, day 4, the fever is still persisting, and by this time, the patient has developed a left-sided flank pain. So now you go for an imaging, abdomen, contrast CT, you go for the abdomen at this point. And now what do you see? The left kidney, you can see this particular lesion in the left kidney. By this time, you had already sent for blood cultures, and they had told that initially they had seen GNB. By this time, after the flagging of the blood culture, they have done the BioFire. What is BioFire? BioFire is a multiplex PCR-based test. So the BioFire, they tell you that they have identified the organism in the blood. So the organism is Klebsiella pneumonia, which is an enterobacterial. And the BioFire, we also know that it tells us about the various antibiotic resistant genes. So that it tells us that this particular antibiotic resistant gene has been detected, CTXM. So could you please scan this QR code? So the blood BioFire, it tells us that Klebsiella pneumonia has been detected in the blood, and the antibiotic resistance is CTXM. So can you please scan this QR code? Done? Okay. Wait. Let me ask. So my question to you, 2 questions are: number 1, what is the mechanism of resistance seen in this particular case, seen exhibited by this bacteria? And number two, the patient was given a third generation cephalosporin. Would you like to upgrade the antibiotic in this particular case? So these are my two questions to you. Answer these two questions. Okay, most of you have correctly answered. The drug to be used is meropenem. What is the mechanism of resistance? Next question. Okay, so most of you have correctly answered both the questions. So the CTXM, it is actually exhibiting something called as the ESBL. And in ESBL, the correct antibiotic to give in such a case would be meropenem. So what is exactly ESBL? So ESBL, extended spectrum beta lactamases. We know beta lactams, they'll kill the beta lactam ring. They are capable, what they do is they hydrolyze the third and the fourth generation cephalosporins and the monobactams. However, these beta lactamases, they can be inhibited by the BLIs. The BLIs I had told you before, we have the newer BLIs, the older BLIs, including clavulanate, sulbactam and tazobactam. However, even though they are inhibiting the third and fourth generation cephalosporins, they do not confer resistance to the cefamycins. And in India, the most common variant which we see is the CTXM, which is seen mostly in the enterobacterials. So these are some examples of the ESBLs. So I showed you that particular chart. A lot of ESBLs were mentioned there. So these are some of the beta lactamases which are ESBL. So we can see that if the organism is producing ESBL, all the antibiotics which are highlighted in red, we cannot use them. They won't be effective in such cases. So by this time, the blood culture report has also come, and we can see that all the third generation cephalosporins, they are resistant. Imipenem, meropenem, they are sensitive. And according to the IDSA, which according to their guidance released last year, the appropriate antibiotic to be used in such a case is a meropenem and imipenem. So whenever you get a case of ESBL, it is better to change the antibiotic to a carbapenem in such cases. So here you can see that piperacillin tazobactam is sensitive actually. So would you prefer giving this patient piperacillin tazobactam? In a patient, you have seen that the blood culture, it is resistant to third generation cephalosporins. You know it is an ESBL. Would you like to give piperacillin tazobactam to such a patient? So in such cases, it's better you do not give piperacillin tazobactam, because some studies have been done, specifically this Merino trial. So in this Merino trial, what they did was in patients having bacteremia with an ESBL organism, they compared piperacillin tazobactam with meropenem, and it was actually seen in the primary outcomes there was an excessive mortality in those individuals who have received piperacillin tazobactam versus meropenem, 12.3 versus 3.7. So in such cases, specifically, more importantly, if the patient is very sick and you see that the ESBL containing organism, piperacillin tazobactam sensitive, you should not give piptaz to such a patient. Better you give the patient a carbapenem in such case. So the take home point of this case would be, in case of ESBL producing organisms which you identify by resistance to the third generation cephalosporins, you try to use carbapenems. So the second question now would be, this patient, so basically she had a renal abscess, which was around 10 mm size. So because of its small size, it was not drained. The patient was started on meropenem, and after starting meropenem, the fever resolved on day 5 itself. And then later you do a CT scan, and you see that abscess is decreasing. So now the patient has been stabilized. You plan to discharge the patient. However, because the abscess size is more than 3 mm, so she requires a prolonged duration of antibiotic. So you have to give something to the patient on an OPD basis. So what antibiotic would you choose to give to this patient on an OPD basis. This patient, ESBL, you prefer carbapenem in such patients. What antibiotic would you choose? Okay, many have answered as ertapenem. But the most common answer is an oral ferropenem. So it is understandable why we would try to give ferropenem. Ferropenem is an oral antibiotic. It will be very convenient for the patient. But you should not give ferropenem to the patient. I'll come to why. So the thing with ferropenem is, it is an oral carbapenem antibiotic, but it is approved only in India and Japan, and there are very less number of studies actually validating its use. Because of which we actually don't have any standard dosing schedules as well. Though it is marketed as a broad spectrum antibiotic, we can see that it is active against gram-positive and gram-negative organisms. But if you look closer, you will see that whenever the organism, the gram-positive or the gram-negative organism, it gains some amount of resistance, this ferropenem, it is not, it does not have any activity against such organism. The moment some amount of resistance is acquired by the organism, for example, ESBL, AMC. And another very big problem with this ferropenem is, whenever you give ferropenem to an individual, there will be a quick acquisition of resistance to all carbapenems, not just ferropenem. So whenever, actually, if you try to compare ferropenem with meropenem, you see that the spectrum of activity of ferropenem is much lesser than that of meropenem. How so? It is not active against ESBL producing organisms. It is not active against Pseudomonas aeruginosa. Meropenem, it has very good activity against the anaerobes, but we can't say the same for ferropenem. And lastly, meropenem, if you give it to the patient, you can give it for say 1 to 2 weeks without the acquisition of resistance. But in ferropenem, give it for 1 to 2 weeks and there will be rapid acquisition of resistance. And later on, if you want to give meropenem to this individual, that meropenem won't even work. So, because ferropenem, it has limited activity against ESBL. ESBL, we know that if you give third generation cephalosporins to ESBLs, it will not work. So cefixime is also third generation cephalosporin. So basically what we see that ferropenem is no better than cefixime. So it is actually a loss giving ferropenem to individuals. You should never give ferropenem therapy to any individuals because of these reasons which I just told. Another question. So this patient, so we will not give ferropenem to this patient. So the proper choices would be either between giving IV meropenem or IV ertapenem. So these two are good options. There are certain points we need to consider before actually deciding which one to give. So the ITSA 2024 guidelines, they have also mentioned in such cases complicated UTI, whether meropenem, imipenem, ertapenem, we can give any of those. So there are certain things you should keep in mind before giving ertapenem. So ertapenem, it has once daily dosing. It is very convenient for the patient, especially those patients who are receiving OPAT, outpatient antibiotic therapy. But the problem with ertapenem is its spectrum of activity is not as good as that of meropenem. How so? It is not active again. It is not as active against Pseudomonas aeruginosa, Acinetobacter, and certain gram-positive organisms. And the ESBL activity, which we discussed prior to, it is not as good as, say, meropenem. Another thing is, this is a very highly protein-bound antibiotic. As such, whenever there is hypoalbuminemia in any individual, the blood concentrations, they fall. And certain studies have shown in such patients, there is actually an increased mortality if you give ertapenem to such individuals. Because of its high protein binding capacity, what happens is, it is unable to cross the blood-brain barrier because free concentrations are not achieved such. So you cannot use it against meningitis, you cannot use it in hypoalbuminemic patients. And if you have seen any culture sensitivity report of any enterobacterals, you will notice that meropenems, they tell us about meropenem, imipenem susceptibility. They don't tell us about ertapenem. So in light of this information, that ESBL activity is not good. Perhaps the ESBL MIC might be higher We don't know. So whenever, if you are deciding to give ertapenem to such an individual, it's better you call the microbiology lab and ask them what is the MIC. So if the MIC, the minimum inhibitory concentration of that particular isolate, if it is less than 1 microgram per ml, ertapenem is a good enough choice. If it is not so, it would be better to give meropenem to that patient. So another case, a 72-year-old female, known case of type 2 diabetes with hypertension with bilateral TKR. So now presented to you with left knee pain and swelling. So when she presents to you, you suspect it to be a prosthetic joint infection, and you take an synovial aspirate, which shows a very high TC of 3000, which is predominantly neutrophilic. You do a CT and you see intrasynovial fluid connection and a periosteal reaction. So now you know it's a case of prosthetic joint infection. And in any case of prosthetic joint infection, you try to get out the infected prosthesis out, so which you do. So the patient undergoes a two-stage procedure, undergoes the first stage of a two-stage procedure. So prosthetic joint infection, what happens is, you remove the prosthesis and then you put antibiotic spacer with cement. And once the infection resolves, then you replace that antibiotic spacer with cement with a new prosthesis. So she undergoes the first stage replacement, and intraoperative cultures are collected, and you find it has grown Pseudomonas aeruginosa. And this is the AST. This is the antibiotic susceptibility which you have gotten. So now my question would be, what would be the correct antibiotic to give in such a case? What would be the correct antibiotic to give in such a case? Meropenem. Imipenem 10%. So most of you have answered it as meropenem. So one thing about such cases is, this prosthetic joint infections, generally the treatment duration is very long because it's a muscular osteoarticular infection. The antibiotic penetration in bone is mostly poor compared to other tissues. So you have to give antibiotics for a very long period of time. Often it extends into, say, something like 6 months, 7, 8 months. In such cases, antibiotics you have to give. In such cases, compliance becomes a very big issue. It becomes a very big deciding factor. So you might be tempted to give ertapenem 1 gram because this will have better compliance for the patient. But again, you should remember that ertapenem, its activity against Pseudomonas is lesser than that of meropenem. And even if you feel that compliance is becoming a big issue, you can call up the lab and ask for the MICs. If you feel that, no, this patient requires ertapenem, and if the lab tells you that the MIC is less than 1, then you can go ahead with ertapenem. Otherwise, the default choice should be meropenem for this particular case. So we had actually discussed ESBLs, and we have discussed that in ESBLs, what is the drug which is to be given. We have come to a conclusion that generally carbapenems, they are the better drugs to be given. And of carbapenems, ferropenem is not a good drug. Ertapenem, subject to certain conditions, you can give. However, coming to this complicated UTIs, are there any other therapies which we can use? So my next question to you would be, of all these antibiotics, are there any other therapy of these antibiotics? Would you choose any of them for an ESBL infection, extended spectrum beta lactamase infection? Would you use any of these drugs? Multiple answers might be correct for this. So actually, for complicated UTI, so we can use most of these drugs. Phosphomycin and nitrofurantoin we won't be using in complicated UTI. We'll be just using it in cystitis. Why? Because these two drugs, they are mainly concentrated in the urine. So it is good for cystitis. But any upper urinary tract infection, they might not achieve that required concentration which is required, for example, say in a case of pyelonephritis. So in those cases, we would prefer some other drugs. So fosfomycin nitrofurantoin, we can use it in ESBL if it is cystitis. Otherwise, we won't use it. And these drugs, we can use it for both complicated and uncomplicated UTIs. Ciprofloxacin, levofloxacin, Septran, aminoglycosides, and this new drug, cefepime and metazobactam. So we must actually know that what happens is ESBL, they are resistant to the beta-lactams. They have not developed resistance to this other antibiotics, the fluoroquinolones, Septran, aminoglycosides. They are just resistant to the beta-lactams. So if the culture sensitivity report tells me that this organism is susceptible to fluoroquinolones, to aminoglycosides, we can give those particular drugs to them. Which is also, this is advocated by the 2024 ITSA guidelines, which says that we can use these particular drugs for complicated UTI. So this particular drug, cefepime N-metazobactam, it's a new drug. It was just, I think, released last year, and it has been adopted by multiple official bodies across the world. So, so this drug was released last year itself, and across multiple studies, it has shown its good efficacy. So actually, this particular study, which was published 3 years back in JAMA, so what they did was, in complicated UTI infection, they gave to one population, they gave piperacillin tazobactam, and to the other population, they gave this drug, cefepime and metazobactam. And they looked for the primary outcome, which was in terms of resolution of the infection and decrease in the colony-forming units in the urine. And they found that cefepime and metazobactam, it fared much better than piperacillin tazobactam. So the results were significant, and it was this drug, it seemed to be superior to piperacillin tazobactam. The difference between these two, it was 21.2%. So after that, this drug was adopted by various bodies across the world. So what is this cefepime N-metazobactam? We know piperacillin has tazobactam. Tazobactam is one of the older BLIs. So instead of tazobactam, this particular drug has N-metazobactam. What happens here is one additional methyl group has been added, and it is in the zwitterion format. So because of this particular changes, what happens is now this particular drug is attracted more towards this beta-lactams. It is able to better inhibit this beta-lactams. And second thing is, because of its zwitterion property, it is able to penetrate the tissues even better, and it has a greater half-life because of this. Because of these properties, it is superior over piperacillin tazobactam. So how is it administered? It's administered as a 2.5 mg dose. Like other beta-lactams, it is given in a TDS dose. So it has been adopted by India and the European Medicine Agency. So they have told that it can be used in complicated UTI, in HAB, VAP cases, and in associated bacteremia. The US, they have approved it only for UTI. And the UK approval body, they have adopted it for UTI, certain types of pneumonia, and in certain cases of bacteremia. So the dose, again, if it's a very moderate infection or a severe infection, 2.5 gram TDS over 2 hours. And if it's a severe infection, then you administer it over 4 hours. And this is the, in case of any renal dysfunction, this is the dose modification. So the take-home point would be, in ESBLs, you give carbapenems, but apart from carbapenems, there are other options as well. And from this point onwards, I think it's we can start using cefepime N-metazobactam specifically for UTI. Another case, a 34-year-old female who comes to you with bowel perforation complicated by intra-abdominal abscesses. Now she undergoes the exploratory laparotomy with peritoneal washout, hemicolectomy and ileostomy, and complete source control is obtained. So basically intra-abdominal perforation, intra-abdominal pathology, she is started on a broad gram-negative coverage and a antifungal coverage. And all the fluids which are collected during the surgery, they are sent for culture sensitivity. So it is seen that she grows 2 organisms, she grows E. coli and Klebsiella aerogenes, and you can see that it is pan-sensitive. Fine. So based on this culture sensitivity report, what the doctors do, that they change the piptas to a lower grade antibiotic, they change it to ceftriaxone, and because no candida has grown, they stop the caspofungin. However, what happens on day 4, she clinically worsens, there is fever, the TLC goes up, and repeat imaging is done, and they shows that there are new fluid collections around her liver and in pelvis. And the surgical site, it is seen that there is a brown discharge. So abscess drain is placed, and again, new cultures are sent from this abscess drain. Now what is seen, that in the new culture, there is no E. coli. However, this Klebsiella, again we grow the same organism. However, now it is not a pan-sensitive, the AST is not pan-sensitive. There is some resistance, specifically to cefotaxime, ceftazidime, and ceftriaxone. So, can anybody tell what has actually happened? Same organism, we are giving antibiotics, but now the resistant pattern has changed. And in such cases, what antibiotic would you like to give in such cases? So this is actually something called as the phenomena which we are seeing is the expression of another beta lactamases, which is called as AMP-C. Fine. So what is clinically important for us is this inducible AMP-C, which is encoded on the bacterial chromosomes. So what happens is, initially, they will be, the AMP-C production won't be there in such organisms. But whenever these organisms, they are exposed to a certain inducer, this AMP-C, it will be de-repressed. And they will start producing the beta lactamases, and they will act on the antibiotic and break it. So initially, it is not being produced, but on exposure to antibiotic, beta lactam is produced, and they will break it. There are other types of AMP-C as well, but they are constitutively, they are always being produced. In such cases, we won't see this phenomenon, that is, when initially the bacteria will be sensitive, but after giving antibiotics, the patient will worsen, and repeat cultures, it will show now new resistance has developed. So which organisms are notorious for producing AMP-C? So it has been seen that certain organisms, they are at a moderate risk of producing AMP-C. That is, up to 20% of cases, they might produce AMP-C. And we have a mnemonic for it, which is called as HEC-KS. But of this HEC-KS, the most important are these 3. So what happens in AMP-C, I told you that there is an inducer. AMP-C is expressed, and then they will break the beta-lactam ring. So, so there are certain strong inducers and weak inducers. So whenever the strong inducers are present in the environment of the bacteria, AMP-C production will go up. So these are the strong inducers, the first generation cephalosporins, cefoxitin and all, imipenem. And these are the weak inducers, ceftazidime, ceftriaxone, cefoxactin. Imipenem, it is a very strong inducer, but the AMP-C won't be able to break the imipenem beta-lactam ring. And cefepime and meropenem, these are both weak inducers. If the bacteria is exposed, they will not express AMP-C, and they are poor substrate. Even if it is expressed, they won't get hydrolyzed. So you can see here, this is the way we see for AMP-C production in the lab. So here we have the cefotaxime disc, and here we have the ceftazidime disc. They are both weak inducers. So you can see here, especially here, you can see the bacterial zone of inhibition is quite high, because here cefotaxime has not induced AMP-C production. But here you can see that imipenem, in the presence of imipenem, which is a strong inducer, AMP-C is produced, and now there is zone of inhibition has lessened. Imipenem, there is no decrease in the zone of inhibition, because though it is a strong inducer, it is a very poor substrate. So this is how we identify AMP-C in the lab. So what drug would you like to give in such a case of AMP-C production? Obviously, it would be cefepime or meropenem. In such cases, so this particular individual, she was giving injection cefepime 2 gram TDS as an extended infusion. However, there are certain cases in which you can give ceftriaxone in AMP-C producing organisms. So those organisms which have a very low risk of AMP-C expression, so these are the organisms, Serratia, Morganella, Providentia. Even if you give ceftriaxone, the chances of them expressing AMP-C would be quite less. In those cases where there is actually a very low bacterial burden, or in those cases where adequate source control has been achieved. For example, low bacterial burden would be uncomplicated cystitis caused by a moderate risk AMC producing organism, or a low bacterial burden disease, for example, cellulitis caused by Serratia. In such cases, the initial report, if it says it is sensitive to ceftriaxone, you are a bit worried that it may express AMC, but it might be safe in such cases to go ahead with ceftriaxone usage. So whenever you come across this HEC organisms, Hafnia, Enterobacter, Citrobacter, and Klebsiella aerogenes, you should suspect AMC and always give the patient either a cefepime or meropenem in such cases. So another case, some metronidazole. Sir, say this initial patient was given piperacillin tazobactam. So piperacillin tazobactam, it has adequate anaerobic coverage. And once we got the culture sensitivity reports where there was no anaerobic bacteria, so then it was de-escalated to ceftriaxone. Another case, a 52-year-old male, known case of type 2 diabetes with hypertension with dyslipidemia with coronary artery disease, recently underwent angioplasty 2 weeks ago, now presenting to you with fever, with cough, with expectoration and shortness of breath. At presentation, you see that the BP is on the lower side, the patient has tachycardia, and there is some hypoxia, 86% saturation on room air. On examination, you find that there are axillary and intrascapular crepitations are present. Initial labs, they show a very high TLC, some kidney dysfunction, raised CRP and procalcitonin, and on X-ray, you see bilateral middle and lower lobe infiltrations are there. The patient, there is a falling GCS in such patients, probably due to septic encephalopathy, so you intubate the patient and immediately take ET samples. You send for culture and biofires for this patient. And empirically, you start the patient on injection meropenem and teicoplanin. Meropenem is started why? Because initially the patient has a recent hospital visit, chances of the patient having an MDR organism. So because of that, the patient is started on this meropenem and teicoplanin. Now, the biofire, usually it comes within 1 day itself. So the biofire, you see that 2 organisms has been isolated, E. coli and Klebsiella pneumonia. Klebsiella pneumonia is 10 to the power 7. And E. coli is 10 to the power 4. So most probably, this might be contributing more to the disease burden than the E. coli. And you see some antimicrobial resistant genes also which have been expressed. You see that CTXM, which is an ESBL, that is there in the microorganism. The KPC, the OXA48 is present and NDM is present. So, apart from ESBL, some another genes also have been expressed. What are those genes? Before coming to the genes, by this time the culture sensitivity also comes and you see that it is resistant to all other antibiotics except for tetracycline. It is resistant to all other antibiotics. So what would be a good antibiotic choice in such case? What would you like to give? Okay, so before going to the answer, I'd just briefly talk about the various beta-lactamases. I had told you before that we are having 4 classes of beta-lactamases. Class A, B, C, D. In class A, so just remember that only the class B, this is the metallo-beta-lactamases. Rest, all of them, they are serine beta-lactamases. The ESBLs, they come under this class A. Now, we have another set of beta-lactamases, which are the carbapenemase. Whenever they get a carbapenem, they will break the carbapenem. Now, this carbapenemase, they are actually distributed both in class A. Class A, we have something called as the KPC. So, you will find carbapenem in class A, KPC, you will find this metallo-beta-lactamases. These are also carbapenemase. And finally, in group D, you have the OXA48. These are also carbapenemase. So, basically, carbapenemase, they are divided over class A, class B, and class D. So, the KPC, Klebsiella pneumoniae carbapenemase, belongs to group A. The class D, the OXA group, belongs to class D. Most important in India, we have the OXA24, OXA48. These are the most important. We need to remember that the group A carbapenemases, they can be deactivated by the newer BLIs. So, avibactam, relebactam, vaborbactam. So, whenever you give these beta-lactam inhibitors in a suspected case of KPC, these antibiotics will be effective. However, this class D carbapenemase, of which OXA48 is there, OXA48 was present in our patient. In these, only avibactam will work. Relebactam, vaborbactam, these won't work. This class B carbapenemase, which are actually the metallo-beta lactamases. Why are they called metallo? Because they have a zinc ion in their active site. So this can be deactivated by the EDTA. They are resistant to all BLIs. All beta-lactam inhibitors they are resistant to. However, they are not susceptible to, they are susceptible to monobactams. All of us, we know about the NDM, the New Delhi metallo-beta lactamases, which was found from India. So basically, what we do is whenever we get a carbapenemase, either it is a serine beta lactamase, group A, group C, group D, or it is a metallo beta lactamase, group B. We know that serine beta lactamases, avibactam, will inhibit all serine beta lactamases, and the metallo beta lactamases, they will be inhibited by aztreonam. So whenever we are getting a carbapenemase, we should try to send for the gene which is present. We should try to send for the rapid carbapenemase test. They will tell us what gene is present. In our case, the patient, she had a metallo-beta lactamase and OXA48. So OXA48 is a serine beta lactamase, so we have to give avibactam. Avibactam, we generally get it as ceftazidime avibactam. So we have to give the patient ceftazidime avibactam, and because the metallo-beta lactamase is present, we have to give aztreonam to this patient. So this is the drug dose which has been given to the patient. And you must keep in mind that both this ceftazidime, avibactam and aztreonam, there are two, they come in different packages. So you'll have to administer them at the same time. You should not try to administer them at different times. Why? Because when both these drugs are given, then both these enzymes will be inhibited simultaneously. And only when both these enzymes are inhibited simultaneously, then only the bacteria will die. If only one of them is inhibited, the other one is not inhibited, the bacteria won't die, and giving this combination at different times won't be effective. So the last question would be regarding this particular patient only. We saw that patient only tigecycline was sensitive. So suppose if this patient had primary bacteremia, would you have thought of a different antibiotic? Would you have given this patient a tigecycline monotherapy in this case? Keeping in mind that tigecycline is a very good broad spectrum antibiotic. Would you have given tigecycline to this patient? So most of you have answered no, give ceftazidime avibactam, which is the correct answer. So why don't we give tigecycline monotherapy in such patients? It is because number one, because of certain reasons. What is it? It has actually very good tissue penetration. It has so good tissue penetration that when it is administered, it immediately leaches away from the bloodstream and it enters into the tissues such that there is no adequate blood concentration. And because there is no adequate blood concentration, when the blood is filtered through the kidneys, there is no adequate urine concentrations. So because of this simple reason, you should never give tigecycline for any bloodstream infection or for any UTIs. So however, tigecycline, you can use it as a monotherapy in certain cases. What are there? It can be one of the preferred drugs for skin and soft tissue infections. And in certain cases, you can use it for community-acquired pneumonia. Though this is not an empiric choice, but you can give it as monotherapy. And obviously, we know that this particular drug is used as a combination therapy in carbapenem-resistant Acinetobacter baumannii infections and intra-abdominal infections. So the take-home point from this case would be, whenever you are finding carbapenem resistance, you try to see what gene is there. If it is a metallo-beta lactamases, give ceftazidime avibactam plus aztreonam. If it is KPC, give ceftazidime avibactam. Or if it is OXA48, give ceftazidime avibactam. These drugs, meropenem, vaborbactam, imipenem, cilastatin, relebactam, and cefiderocol, they are still not available in India. So KPC, OXA48, ceftazidime avibactam, MBL, ceftazidime avibactam, aztreonam, and do not use tetracyclines for any bacteremia or UTI. This is just a brief summary of the various beta-lactam inhibitors and what are the susceptibilities. If you want to just look at the main points, we can see that avibactam, it can break all kinds of carbapenemase, but it won't inhibit metallo-beta lactamase. Aztreonam, it will be destroyed by all beta-lactamases, but it will kill the MBLs. And the last topic for today would be the carbapenem-resistant Acinetobacter baumannii. So we know many of our patients in the hospital, they are getting Acinetobacter baumannii infections. And mostly they either cause a surgical site infection or they cause lung infections. But it is important to remember that Acinetobacter, it is quite prevalent in the hospital settings, and it can exist as a colonizer. Not all Acinetobacter isolates are necessarily pathogenic. So first of all, you have to identify whether it is a colonizer or whether it is a pathogen. It's especially we can see cases where a patient who might have come with a VAP is now improving on antibiotics. The CRP is going down, X-ray picture is improving, but has suddenly now the ET cultures have grown Acinetobacter. That is probably a case of colonizer, and you do not need to treat that particular organism. Now, this carbapenem-resistant Acinetobacter baumannii, they have actually having many mechanisms by which they gain carbapenem resistance. It is not just having one or two beta-lactamases. They can have the oxacarbapenemase. They have something specific, a cephalosporinase, which is called as the ADC. They might have altered PBP. They might have aminoglycoside modifying enzymes. So a lot of mechanisms these organisms will have. And because of such, it becomes very difficult for us to choose an appropriate regimen for this carbapenem-resistant Acinetobacter baumannii. So one of the major ways by which it gains resistance is the PBP3, the penicillin binding protein 3, of which this sulbactam is actually effective against. Now, in countries outside of India, especially the Western countries, this particular drug combination has been approved. Sulbactam, durlobactam, along with imipenem or meropenem. However, in India, where this drug is not approved, what do we try to do? We try to give a very high dose sulbactam. Why high dose? We try to saturate all the PB3, all the penicillin binding protein 3, all the attachment site, we try to bind them by giving a very high dose of sulbactam. Once that is occupied, we give another combination therapy. For example, we can combine it with either poly-B, minocycline, tigecycline, or cefiderocol. So we try to follow this particular combination therapy whenever we are getting carbapenem-resistant Acinetobacter baumannii. However, there are certain things we need to consider. For example, if you are giving polymyxin, two types we know, colistin and polymyxin B. So we give colistin for urinary tract infections. Why? Because the pharmacokinetics in the blood for colistin is actually very unreliable. It converts in the active form only in the urine. We are not sure in the blood whether if it reaches adequate bactericidal concentrations or not. So it is effective only in the urine. And this poly-B, it follows the opposite. It is never excreted in urine. So any other tissues, it will go, it can achieve a adequate concentration. It can achieve, not necessarily it will achieve, it can achieve. So for urinary tract infection, you try to give colistin. For any other infection, you give poly-B. If you see the culture sensitivity report in such cases, you will see that polymyxins, they are never reported as sensitive. Maximum, they will be reported as intermediate. Why? Because whenever you report something as sensitive, it is in a certain way saying it's a guarantee that if you use this particular drug, there will be some sort of a response. However, we cannot say the same for polymyxins. Why? Because at the conventional dosing strategies, the serum concentrations, they are quite variable. Different people might have different serum concentrations, and this drug has a very narrow therapeutic window. You must have seen that this drug causes a lot of AKI, the kidney dysfunction it causes, because of this narrow therapeutic window. And lastly, in the epithelial lining fluid in the lung, the activity is highly variable. So even after giving the, say, recommended dose of polymyxin, there might not be a response. So because of this reason, there is no susceptible category for this polymyxin B. And you will not get it as sensitive, intermediate, resistant. What you will get is the MIC. So whenever you see that MIC is more than 2, I think it is fair to assume combine the high dose sulbactam with tigecycline or minocycline. High dose sulbactam is what? 6 to 9 grams per day. In our hospital, we get isolated sulbactam. Generally, in other places, we get sulbactam as a combination. For example, ampicillin sulbactam or cefoperazone sulbactam. But in our hospital, we get it as an isolated sulbactam. So we have to give 6 to 9 grams of sulbactam per day and combined with either poly-B, minocycline or tigecycline for carbapenem-resistant Acinetobacter baumannii. So with this, I come to the end of my presentation. If there are any questions, I'd like to take them now.
Thank you, Dr. Imtiaz, for that very interesting presentation, for taking such a complex topic and breaking it down into simple things that we can understand for our clinical practice. For the interest of time, we'll take maybe 1 or 2 questions. Yeah, Jessica.
Thank you, Dr. Imtiaz, for that excellent presentation. Just one query regarding Cefepime and Metazobactam. Because after the Merino trial, we changed our practice of not giving piptas for the patient who was septic. We said even if it's ESBL sensitive to piptas, we say we give meropenem.
Yes, ma'am.
Can we replace in those situations instead of meropenem, Cefepime with enmetazobactam?
Yes, ma'am. So it is actually being marketed as a carbapenem sparing antibiotic.
In sicker patients, can we use it? Like I know if it's just a UTI and with bacteremia, because it did mention in bacteremia we can use, but in septic, with sepsis in ICU, can we replace meropenem with this? Because then it will be very good.
Ma'am, so basically, in most places it is approved only for UTIs, complicated UTIs, not for bacteremia. In India and in Europe, it has been approved for bacteremia, so that is their number one. Number two is it has just been released 2 years back, and most of the studies, they are also limited. The few studies which were there, for example, the JAMA study, it showed it to be a superior to piperacillin tazobactam. Number three is recently there was a conference where people who have started using this Cefepime and Metazobactam, they were telling about their experiences. So I think in Lucknow, in Medanta, Lucknow, they have actually used this drug, and they have used it in renal transplant patients as well with good success. Now I don't know exactly if they have used it in sepsis patients or not, but in high-risk patients also they have used this drug with good success. I think as of now, only 2 years this drug has been released. We have to wait for further reports.
So I think to start off with bacteremia, not very sick, we can start using, and let's see how
Yes,
it
ma'am.
works. Yeah. And one more question. What I understood was for ertapenem, pseudomonas, its intrinsic resistance is what I understood. So we wouldn't even check for it, no? So micro doesn't even put ertapenem into the list. Even so, there's no question of MIC there, is what I understood.
For Acinetobacter and Pseudomonas, it is generally resistant,
Thank
so
you.
not preferred to give. For other enterobacterals, if you want to give ertapenem, you check the MIC concentrations.
So just one more question if anybody is having, or else we can close the session for today. All right. Okay, thank you everyone. Thank you Dr. Imtiaz for this wonderful presentation. I think we'll meet for the next quest for next Thursday. Thank you.